I would like to extend a very warm welcome on behalf of DocTutorials and RRM Next Institute for this surgical group Unite test series. I am Dr. Mithun Raam. I am your endocrine and breast surgery faculty. And in this week's test, we have covered these three very important topics: thyroid, parathyroid, and adrenal gland. And I'm going to be discussing these questions one by one. When we look at last year's NEET paper, there was quite a bit of questions that did come from endocrine surgery, especially from parathyroid. We did get a lot of questions. And the other important thing that you need to note is that a lot of these questions were actually from clinical perspective, from a clinical angle. So that is something again that we can expect in the upcoming week. So one more point which I want to drive across to you before we move on to the test discussion is that last year we found that there were a lot of questions that did come from Schwartz textbook. Again, that's some thing that we need to keep into consideration. So we need to go a little bit beyond Sabiston to kind of make sure that we cover everything for endocrine surgery. So I've done that in this test. So let's look at each question. I've tried to make all the questions clinical oriented, a little bit of twist in most of these questions. So I hope you had enjoyable time attending this test as much as I enjoyed preparing these questions for you. So let's look at the questions one by one. So let's go on to the first question. So this is a clinical scenario again. So 72-hour-old neonates who developed abdominal distension with no passage of meconium, and examination of this neonate revealed a normal renal patency. So, on further family history, the father was diagnosed with medullary thyroid carcinoma and underwent surgery at 30 years old. One sibling also had a right solitary thyroid nodule, which showed a plasmacytoid appearance and FNAC with salt and pepper chromatin. So, which of the following genetic loci is likely responsible? So, let's just break down this question before we go into the options and then we look at the answer. This is the options are pretty straightforward. There's not much of explanation to give to the question, to the answer. But the clinical scenario we need to understand. So remember, this is a neonate, 72-hour-old, and this is somebody who is not passed meconium even after 72 hours. So normally, by 48 to 72 hours, meconium in a normal infant is usually passed. Examination again here, this is shows that this is not an anorectal malformation or impatient renal opening. So here there's a normal renal patency. Important thing in this question is the family history of medullary thyroid cancer. So this is medullary thyroid cancer, and this is diagnosed at a very young age, it's at 30 years of age. So that's a very important, significant history that we need to understand. And you can see another sibling also has a right solitary thyroid nodule. They have given you the FNAC, but here I have not given you the diagnosis. So I have just given you a rather descriptive feature of the FNA, which you are supposed to analyze and figure out what the FNA denotes. So here, if you look at the FNA of the solitary thyroid nodule, you can see it has got a plasmacytoid appearance. So plasmacytoid appearance, or in other words, the cells are looking like plasma cells. And of course, you have this characteristic appearance, which is salt and pepper chromatin. So the salt and pepper chromatin is a very classical finding that is found in a lot of these neuroendocrine tumors, especially medullary carcinoma thyroid. So remember, in an FNA, if you get a plasmacytoid appearance, it need not always mean that it is a medullary thyroid cancer. So remember these additional points apart from the question that we're discussing. So this plasmacytoid appearance is something that is not particular to biliary carcinoma thyroid. It may occur in other undifferentiated or dedifferentiated thyroid cancers. So sometimes in a poorly differentiated thyroid cancer or in anaplastic thyroid cancer, also you can get this plasmacytoid appearance. So remember, this plasmacytoid appearance is only given as a clue. The more important clue here, or the name in the topic is actually the salt and pepper chromatin. So now we have a clinical picture here of basically a strong family history of medullary thyroid cancer, and we're also having this neonate who is unable to pass meconium. So this is basically a clinical picture of Hirschsprung's disease like syndrome along with medullary thyroid cancer, along with familiary medullary thyroid cancer. So let's look at the options now. So we've got two components here. We've got a chromosomal component and we've got a codon component. Now this is where the options are getting a little bit more tougher. So we've got a chromosome 10q11.2, chromosome 11q 12.13, and these are the two basic chromosomal loci that are given to us. And you also got different codons. Now, we are classically in this clinical scenario, what we're talking about is a familial medullary thyroid cancer along with a Hirschsprung disease. So, medullary thyroid cancer with medullary thyroid cancer with Hirschsprung disease is classically something that is seen in men 2A, so multiple endocrine neoplasia, 2A syndrome. And now, so when we look at the option, this 918 gets ruled out because 918, M918T mutation, as you all know, is a classical mutation that is found in the men 2B syndrome, that is the highest risk of risk stratification according to the American Thyroid Association. So 918 straight away gets ruled out. So now we have different options: 634, 618, 620. Now, if you look at the three different options, you can look at the men 2 syndrome, both men 2A as well as men 2B syndrome, both belong to they are basically red protontology neurosis. So basically, you're going to get red protontology, which belongs to the locus 10q11.2. So straight away, again, this option is ruled out. Now, when you look at 634 versus 620, the correct answer here is chromosome 11q 2 codon number 620. So remember, let's look at this is a question that I picked up from plots. Now, these are subtle features about multiple endocrine neoplasia that we need to remember. So, if you look at this table, now remember, we know men basically has men 1 and a men 2. Men 2 has a men 2A and a men 2B. Now, we have this newer classification. So, men 1 is still known as men 1. Men 2A, what are previously known as men 2A is now what we call as men 2. Whereas men 2B is now categorized as men 3. Men 4 is a newly described variant, which is basically phenotypically like a men 1, but does not have the many gene mutation. So that's why it's called men 4. So let's look at the options here. Now, if you look at men 2A, now men 2A, remember men 2A is more common than men 2B, is less aggressive. So the common manifestations you have are medullary thyroid cancer, that is there in 95 to 100%, pheochromocytoma in 40 to 50%, and PHPT occurs in about 20 to 25% of the patients. You may get various different variations of this. One of which is basically men 2A with Hirschsprung disease. So if you remember, look at the last row here. It's important to know men 2A with Hirschsprung disease is found predominantly in codon 609, 618, and 620. So among the men mutations, more common occurs in 634. So this is something that you need to know. Now, as I already mentioned, men 2B is specific for codon 918. The clinical scenario, men 2A syndrome with Hirschsprung disease, the codon number involved is 620, chromosome involved, the locus is chromosome number 10, that is a red protontology here. Remember, one interesting point in men 2 with Hirschsprung is if you look at men 2, the other components, they are basically gain of function mutated, right? The red gain of function mutations is what is found in men 2A syndrome for the other components, whereas for the Hirschsprung disease components is actually a loss of function type of mutation. So this is the kind of what's known as Jungli mutation, where you have some components have a gain of function mutation, some components, that is the Hirschsprung disease, is going to have a loss of function component. So this is an interesting fact that we need to know about men 2A along with Hirschsprung. So let's move on to the next question. Now again, this is a clinical scenario. 42-year-old lady swelling in front of the neck. It is moving with both deglutition as well as protrusion of the tongue. So which of the following is the currently acceptable management for this country? So they have given us the clinical scenario. You can see this clinical picture here. This is the midline swelling. So it is the midline swelling of the neck. This moves with both deglutition as well as protrusion at the tongue. tells us that the diagnosis here is a thyroid cyst. So they're asking us what is the current acceptable manual for this condition. So let's go to the options. Excision of the lump along with the body of the hyoid and few centimeters of soft tissue capillary. Excision of the lump, body of the hyoid and the tract all the way up to the foramen cecum. Excision of the lump alone or excision of the lump along with hypothyroidism. So now let's look at each option. So the correct answer, before we, let's look at the correct answer here and then we'll go on to discuss the options. The correct answer here is basically we need to excise the swelling along with a portion of the body of the hyoid. And usually we take about 2 to 3 centimeters of soft tissue capillary to the body of the hyoid bone. Now, why do we do that? Is basically, unlike what we imagine a thyroglossal cyst or thyroglossal tract to be, we imagine it is a single tract. But usually what is found in physiological studies is that the thyroglossal tract from the hyoid bone has these small, short, ramified branches, and they are usually found about 2 to 3 centimeters capillary or towards the foramen cecum from the hyoid bone. So that is why we usually take an elliptical incision along the swelling. With the skin, we dissect all around the swelling, go up to the hyoid bone, cut the hyoid bone, usually can be done with a scissors or maybe a bone cutter if it is occupied, and then we remove about 2 to 3 centimeters of soft tissue capillary. So, if you look at it, the cystral procedure, which was originally described in 1920, that basically was meant for infected thyroglossal cysts. So the original destruction by cystral was actually excision of the tract all the way up to the foramen cecum, in fact, pouring a bit of the base of the tongue in order to avoid recurrence. However, as I've already told you, histological studies show that these tracts usually do not extend all the way up to the foramen cecum. So they are only small ramified branches that are usually found like the body of the hyoid bone. So among the modifications that we have seen, the key component is that you excise the entire cyst, excise the surrounding thyroglossal tract, and very important, you have to excise the central part of the hyoid bone. So why do we excise the central part of the hyoid bone? Because the quantification of the hyoid bone is very closely associated in terms of the time of development to the descent of the thyroglossal tract. So that's why the thyroglossal tract usually descends either anterior to the developing the chondrite hyoid bone, or sometimes they even go through the hyoid bone. So in order to avoid this moving any development in thyroglossal tract, we insist on excising the hyoid bone as well. So resection of the portion of the base of tongue is not done now. That is what the original system figure was. Okay, let's move on to the next question. 44-year-old male with 9 STN, it is hard in consistency. With involvement of the skin, there is no lymphadenopathy. And they have also given us an FNA. So the FNA is basically showing spindle cells, there is necrosis, there is presence of gland cells, and they've also given us an IFC picture. So the IFC tells us that the cytokeratin is positive, TTF1 and calcium is negative, CT does not show any metastasis. So what is the correct stage of the disease? So this is a really complicated scenario. This is basically, as very obvious, this is locally advanced thyroid cancer. So you can see here STN, hard and consistency, all these are again pointing to a pregnancy. Obviously, you can see here that the skin is involved. You can see how the skin is stretched and shiny. And they have also given us that there is no lymphadenopathy. So FLAC shows something of spindle cells with necrosis with gland cells. IFC is cytokeratin. So remember, when we talk about, again, we're talking about a similar appearance with plasmacytoid cells, spindle cells, along with necrosis and gland cells. Usually, this is a feature of a dedifferentiated or an undifferentiated thyroid cancer. This is confirmed by our IFC. Now, look at the IFC very carefully. Cytokeratin positive, again, very strongly suggestive of undifferentiated thyroid cancer. These are more towards the squamous carcinomas than the differentiated variety. So, we often have a squamoid variety of Anaplastic also. The cytokeratin is positive here. TTF1 is negative. That is very clearly telling you that this is not a very different thyroid cancer. Calstone is also negative. Again, points towards the fact that this is not a medullary thyroid cancer. Now, CT is not showing metastasis. So basically, this is going to be an N0 disease. This is going to be an N1 disease. Now, what about the T stage? So now they have not given us the size of the nodule. However, one important thing is the difference that this involves the skin. So remember, whenever the uh, thyroid cancer involves the skin or the soft tissue, it becomes a T4A disease. Okay? So this is basically a locally advanced thyroid cancer, which is of an anaplastic type. So what is the correct answer here? So the correct answer, again, is given to remind you that the confusing part here is that it's also given you the age to compute. Now remember, the age has implications only in a well-differentiated thyroid cancer. So please read the question very carefully, pay attention to this point. Whenever you have a well-differentiated thyroid cancer picture in the question, always think about age. Less than 55, more than 55, less than 55, even a metastatic disease will go to stage 2, whereas more than 55 will go on to stage 3 and stage 4, whereas in undifferentiated thyroid cancer, that does not hold true. Now remember, when we talk about anaplastic thyroid cancer, there is no stage 1, stage 2, stage 3, it straight away goes to stage 4, even to begin with. So completely intrathyroidal, well localized, undifferentiated or anaplastic thyroid cancer, which is stage 4A. So the correct answer here is stage 4B. Alright, so as I already mentioned, T4A because any gross extension into the subcutaneous soft tissue or the skin, dissectable structures like larynx, trachea, esophagus, laryngeal, all these irrespective of the size will be a T4A disease. As we look at it, this is the specific staging for anaplastic thyroid cancer, which is different from well-differentiated thyroid cancer. So if you look at any T4 disease, irrespective of low positive or not, will become basically a stage 4. Alright, so any metastatic will become stage 4C, whereas any locally advanced will become stage 4B. Any more positive will become stage 4B. So completely intrathyroidal with no extrathyroidal extension, with no negative, non-metastatic, only those are restricted to stage 4A. So straight away it starts only with stage 4. So important concept to understand. Let's go to the next question. This is again clinical scenario, straightforward, pretty much straightforward. 28-year-old lady complains of swelling in front of the neck for the past 2 weeks. Now this is basically giving you a background. And this is acquired following URL. She had exquisite pain with point tenderness. Which of the following are true statements regarding this disease? Let's look at the options here. Pretty straightforward clinical diagnosis. I'm sure all of you are able to have no issues with the clinical diagnosis in this question. So the options are associated with lymphocytic infiltration in the thyroid gland. Streptococcus and staphylococcus are commonly associated with the disease. FNAC shows presence of multimutated glial cells, or there is a higher risk of recurrence. So the answer is quite straightforward. The correct answer is FNAC shows the presence of multinucleate glial cells. So you can see here, this is a classical example. Remember, when we talk about thyroiditis, we talk about painful thyroiditis and painless thyroiditis. Now, in chronic lymphocytic thyroiditis, or what is known as Hashimoto's thyroiditis, soma lymphomatous, is basically what is associated with a chronic lymphocytic infiltration of thyroid. So that usually will present as a painless swelling, long-standing duration. Patients may present with hypothyroidism. So that's how usually they will present, typically in women, 30 to 40 years of age group. But here again, that declarant thyroid is not specifically associated with a lymphocytic infiltration. Now, the second option, streptococcus and staphylococcus, these are more commonly associated with acute thyroiditis. Now, acute thyroiditis is also painful thyroiditis, but acute thyroiditis usually will not present like this 2 weeks following URI. So usually that kind of subacute presentation is classical of a declarant thyroiditis. Now, declarant thyroiditis is classically associated with pain and point tenderness, usually enabling ultrasound to phenomenal audit. Risk of malignancy in declarants is not high, whereas in a chronic lymphocytic thyroiditis or Hashimoto's thyroiditis, there is a high risk of both papillary thyroid cancer as well as even an 80 times the risk of having a lymphoma. Right? So remember, the hallmark of acute thyroiditis, declarant thyroiditis is pain and swelling. Sometimes you may get painful swelling, odynophagia, dysphagia, fatigue, low-grade fever, and classical FNA finding is the presence of ganglion. We have this multinucleated giant cells, you have a granuloma like picture, there may be polymorphism cells, there may be lymphocytes, there may be eosinophils. But the classic thing is this multinucleated giant cells, which are typical of a granule. A very simple, straightforward question. So let's move on. So this is a 6-month-old child with congenital hypothyroidism. Which is the following are appropriate for evaluation of ectopic thyroid and dysharmonism. Now, this is a very common scenario we find in congenital hypothyroidism. So typically they are picked up in TSH being high in the cord blood sample. Now there are multiple reasons why somebody may have a congenital hypothyroidism. Usually either there is a problem with the presence or absence of thyroid gland, so thyroid gland may not be fully developed. You may have ectopic thyroid gland which may not be adequate functioning, or you may have some issues with the hormones, the enzymes that are involved in the hormone synthesis, that is what is known as dysharmony. So what is the appropriate investigation for evaluation of ectopic thyroid and dysharmony? Technetium-99 scintigraphy, ODG PET CT, iodine-131 uptake study, or a perchlorate discharge. Now the correct answer here is a iodine-131 thyroid uptake study. Now a lot of you would have gone with the answer of perchlorate discharge test. That's why I'm telling you, read the question carefully. Here it is evaluation of both ectopic as well as dysharmonigenesis. If it is only for dysharmonigenesis, then you can use a perchlorate discharge test. Now remember, technetium per technique is also used for thyroid gland evaluation. You can use it for visualizing ectopic thyroid gland. Now remember, technetium is used for imaging because it can also be transported by the sodium iodide importer. Similarly, perchlorate is also taken up by the sodium iodide importer. That is why it's used for the diagnosis of dysharmonigenesis by using the perchlorate discharge test. Now, the problem with dysharmonigenesis is there may be hormones that are deficient in organification of it. So we not only need to know the trapping of iodine, we also need to know whether the iodine is properly oxidized and organified. So that is possible only with the iodine-131. We cannot figure that out using the technetium because technetium will anyway may be taken up by the sodium iodide importer, but may not be organified or will not be oxidized or organified. So it cannot diagnose dysharmonigenesis entirely. It will be able to tell us whether there is ectopic functioning thyroidism. That is all that it can tell us. That is why we use iodine-131. Okay, next question. This is a 50-year-old lady with weight loss, diarrhea for 6 months, neck swelling for the past 3 months, with reduced eating for the last 2 weeks. TSH is suppressed. I think 334 also was given to the question, 3.72 5 grams per ml. Which of the TRAb level is elevated at 14.2? Which of the following is the most appropriate definitive management modality? So this is a classical example of a grave carcinoma. You can see here, if you pay attention to the clinical photograph, you can see on the patient's right eye, you can actually see active ophthalmopathy. You can see erythema. You can see a corneal ulcer as well. So this is basically a classical example of sight-threatening grave carcinoma or thyroid arteryopathy. This is a we use something called a Yugogo classification. So in the Yugogo classification, any corneal ulceration, opacity, subluxation of the eye, or optic neuropathy because of the arteryopathy, all these 3 things will put them into a severe sight-threatening category. So which is the most appropriate definitive management? Now remember, all these patients have to be, of course, biochemically controlled. So you definitely will need methanol or carbendazole, which is basically a thiazide. But here they are asking the definitive management. Remember, the correct answer to this question is total thyroidectomy. So remember, surgery is a foolproof and quick method to achieve good thyroidism. This is very important to achieve biochemical control and to manage these patients. So definitive management modality is the required word that needs to be noted here. Radioactive iodine is contraindicated in severe ophthalmology. In very mild ophthalmology, you can give, but there is a risk of aggravation of the grave ophthalmology. So usually we use under steroid cover, but in definitely this kind of severe disease, there is no role for radioactive iodine. So when they ask for definitive management for grave, there are only 2 options. Either it has to be radioactive iodine or it has to be surgery. In this scenario, definitely you will go with surgery. Remember, because this thyroidectomy preferred modality in these following situations. The presence of severe eye disease, failure or contraindication to other treatment options, need for rapid reversal or rapid achievement of euthyroidism, presence of suspicious nodules or compressive symptoms, pregnancy or postpartum stage where you can't give it after again. These are all scenarios where you will do surgery. So this, I'm not going to go into this table. This is stated as a Sabiston. You just need to remember that predominantly in patients who are having severe eye disease, we don't do it after surgery. We prefer that we do surgery for the pain. So we would avoid surgery, elderly patients, comorbidities, those kind of patients we would rather avoid surgery. Whereas in pregnant patients, again, in the second trimester, you do have an opportunity to operate on them. So pregnancy is not a really a contraindication for surgery. So if you want anti-thyroid drugs, second trimester, you are still available for operation without with a minimal risk of pregnancy relapse. Next question, 58-year-old male with coronary artery disease, recurrent ventricular fibrillation. He was on amiodarone 200 milligrams once daily, and he was also to have lethargy, fatigue over the past 3 months, heart rate is 90 beats per minute with mild thyromegaly and minimal exophthalmos. All of the following are mechanisms behind this disorder, except inhibition of cyclic AMP-dependent pathway of thyroxine synthesis, Jode-based phenomenon, deiodinase inhibition or cytotoxicity to thyroid. And this is a classical scenario where they're giving patients who are amiodarone. So this is basically an amiodarone-induced thyroiditis. Now remember, an amiodarone-induced thyroiditis has different phases. Maybe a hyperthyroid phase as well. You may have a hypothyroid phase also. So the correct answer here is the one that is not involved in this disorder is the inhibition of the cyclic AMP different pathway of therapy. That is more something that is found, this is a mechanism that is found more with lithium and not with amiodarone. Remember, amiodarone can lead to both hypo as well as hyper. So we all know what is Wolff-Chaikoff mechanism. So basically, the more iodine that you load the thyroid beyond a particular concentration, it basically causing reduced synthesis and reduce the thyroid hormone. However, sometimes there is an inability to escape from the Wolff-Chaikoff effect because of the high iodine content. That particular phenomenon is broad-based phenomenon. So this results in a hyperthyroidism case. So Wolff-Chaikoff will result in a hypothyroid case, and what we do when we give normal iodine, we expect the Wolff-Chaikoff to bring hypothyroidism and reduce vascularity. Jode-based is the opposite phenomenon where the inability to escape from that Wolff-Chaikoff results in hyperthyroidism. Of course, you have this inhibition of deiodinase activity. So because of the deiodinase activity, inhibition T4 is not converted to T3. So again, you have reduced peripheral T3 action. So the inhibition of thyroid hormone entry into the peripheral circulation, there is direct cytotoxic to the follicular cells, so that can again cause cellular destruction of thyroid. So these are the mechanisms where neonatal can cause amiodarone-induced thyroid. Okay. Next question. 32-year-old female with complaints of palpitation, sweating, weight loss, and diarrhea. Evaluation reveals PSX, which is less than 0.001. That is suppressed. FT4 is elevated, 3.7. TRAB is 0.7, which is again normal. And the TRAB upper limit of normal is 2, so less than 2 is normal. Now they are showing us the technetium-99 scintigraphy. Each of the following are that is the most likely diagnosis. Metastasis, thyroid cancer, follicular thyroid cancer metastasis, gestational carcinoma disease, basic secreting PPT tumor, or thyroid hormone resistance. So you can see in this technetium scintigraphy, you have to interpret this image. You can see how basically there is very low or hardly any uptake that is seen in this image here. So remember, the correct answer here is this is probably a toxic state because of follicular thyroid cancer metastasis. So when we talk about causes of hypothyroidism, remember we always use technetium-99 scintigraphy or a radioactive iodine uptake scan to divide them into two. So either they are states where there is a normal uptake or elevated uptake, or there is absent or low uptake. So normal elevated uptake classically is in gray, where you get dilated diffuse elevated uptake. Toxic multifunctional multiple areas of hyperfunctional nodules with the non-functional areas in between. Toxic adenoma, one lobe is functioning, other lobe is suppressed. Neoplastic disease, case of progression to adenoma, thyroid hormone resistance. All these are states where you have elevated uptake, whereas thyroiditis classically of any cause, comatose, failures, or amiodarone-induced acute thyroiditis, hydrogenic thyroiditis, like post radiotherapy or post radioactive iodine, or stoma ovary, all these are classic examples thyroid cancer metastasis or even thyroid following palpation, all these are classical examples are thyroiditis associated with no or minimal uptake on reductive level. It's a very important concept to understand. You have to understand, you have to interpret the clinical picture. So while doing a screening ultrasound for thyroid nodule, we notice a thyroid stone nodule in the right lobe, which of the following ultrasound features has the least risk of malignancy. You can see this clinical picture here. This is a solid nodule. Probably I would say taller than wider. You can't see microcalcification in the picture. Of course, you can see the height is more in the width. So this is a taller than wider, solid, maybe an isoechoic nodule with increased vascularity. So which of these following has the least risk of malignancy? Taller than wider, microcalcification, increased vascularity or irregular margins. The correct answer here is increased vascularity. Remember, increased vascularity is not necessarily a sign of malignancy. So remember, we need to understand these specific characteristics which have higher specificity for indicating malignancy. So these have basically microcalcification, especially fine punctate epithelial foci, markedly hypoepithelial nodules, irregular margins or gross external extension, taller than wider nodule shape, and you can add on actually solid also, solid nodules also. But all these basically have a more than 90% specificity for malignancy. Size may also be a predictor, more than 4 centimeters, again more pointing towards malignancy, but not definite specific predictor. Intraocular vascularity previously was thought to predict malignancy, and however, in starting thyroid cancer, we don't find that kind of raised vascularity. Maybe in follicular thyroid cancer, the intraocular vascularity may be predicted, but it is not nowadays counted as a significant risk characteristic of cancer. So that's a pretty straightforward question. So let's just move on to the next question. Yes. So 48-year-old lady with neck swelling since the last 10 years, with scalp swelling for the past 6 months, is come to you. FNAC basically is given there on the right side. You can see there is attaching the microfollicles with hardly any keloid that you can see there. Nuclear features seem normal. There is no real nuclear grooving, nuclear confusions, or nuclear clearing. So which of the following statements are true regarding this pathology? So very characteristic presentation here. This is follicular thyroid cancer. Presenting with the concertized scalp metastasis in a classical microfollicular appearance of the FNA, no nuclear features, can colloid or classical thyroid TC. So what are the options here? FNAC is easy tool for diagnosis of malignancy, associated with MAP kinase pathway mutations, intermediate risk group due to heavy risk burden, very disease burden, or it's associated with PAC-C TKI mutation. The correct answer here regarding follicular thyroid cancer is that it is associated with PAC-C TKI gamma mutation. Now remember, FNAC cannot differentiate between a follicular thyroid cancer versus a follicular adenoma because we need the presence of capsular invasion to call it a malignancy. So based on FNAC, you can only the report will always get follicular patients will always be follicular neoplasm to rule out follicular carcinoma. So that can only be done on a histological specimen. You cannot use FNA in follicular lesions to differentiate malignancy. These are classically, so there are two pathways, MAP kinase pathway, and you have the PI3K pathway. So the follicular line of tumor usually are associated with the PI3K AKT pathway, whereas the papillary lesions are usually associated with the myoglobin activate protein kinase pathway. So that's a very simple difference. Now, in follicular thyroid cancer, we know there is the dynamic risk type of patients, the low risk, intermediate, and high risk. Now, when we talk about follicular thyroid cancer, remember there is only a low risk or a high risk. Now, if the presence of vascular invasion is less than 4 foci in the follicular thyroid cancer, we have become the low risk. Whereas if there is more than 4 vascular foci that are involved, then it is the high risk. There is no intermediate risk group in the follicular thyroid cancer, and as we all know, it is associated with PAC-C TKI gamma mutation. So you can see these are the different mutations that are involved in thyroid cancer. I'm not going to go into detail. Just look at what are specific for follicular carcinoma. So basically, they are RAS mutation based. The RAS mutation, though it is common, found both for MAP kinase as well as the PI3K AKT pathway. RAS mutations are more commonly found in follicular carcinoma. Paxate, QPR, gamma, again they are more found in follicular adenoma and follicular carcinoma. DRAF and RET mutations, TRK1 mutations, all these are more commonly associated with fatty liver cancer. The terminal mutations are beta-catenin, third promoter, P53, all these are terminal mutations, so they are more commonly present. Only differentiated and undifferentiated thyroid cancer. It's a very important thing that we need to understand. Very important table from slides. Move on to the next question. 24-year-old female evaluated for persistent hypercalcemia following failed focused parathyroidectomy. Index localization was right, superior parathyroidism. Histopathology was, however, suggestive of a peripheral lymph node. So basically, you have a scenario where there is a failed parathyroid surgery. You've taken out a structure which is supposed to be right superior parathyroidinoma, but the histopathology is basically lymph node. We have gone and done a 4-dimensional CT. The 4-dimensional CT is seen shown here. What is the correct diagnosis? Ectopic left superior, ectopic left inferior, utopic left superior, or false posture-uptake in a level 4 lymph node. Okay, so one small correction, index localization to be left superior parathyroid. The correct answer for this question is, first of all, is it ectopic or utopic? This is definitely an ectopic location. You can see that here we have the carotid artery and we have the jugular vein. This is the lesion that was basically found posterior in the carotid teeth. This is an ectopic location. So this is not a level 4 lymph node. Level 4 lymph nodes are usually found in and around the IGM. This is found posterior in the carotid sheath. So this is the ectopic parathyroid, and this is the classical location of a ectopic left inferior parathyroid. So let's look at the explanation here. So remember, usually the inferior parathyroid glands are derived from the third pharyngeal pouch and they migrate down along with the thymus to the lower pole of the thyroid, sometimes even into the superior and superior endostomach. Sometimes the descent of the third pharyngeal pouch may not happen. So we have an undescended inferior gland. So somewhere along the pathway of migration may arrest. So sometimes they may be even found quite high up. They may be found classically near the skull base, maybe mandible. They may be found even above the normal superior parathyroid gland, sometimes in the carotid teeth also. So this is the classical undescended inferior parathyroid gland of the three. Let's we need to understand the question, understand the option and the implication of embryology of the slide. So let's move on to the next question. 14-year-old neonate, 14-hour-old neonate, born by uncomplicated normal vaginal delivery, sudden onset seizures and lethargy, evaluation for the calcium of 15, and there was family history of mild hypercalcemia in 2 previous generations. What is the most likely pre-state to design this condition? The heterozygous CASR mutation, homozygous PTH mutation, homozygous CSR mutation, or heterozygous PTH related peptide mutation. The correct answer here is this is a homozygous calcium sensitive receptor mutation. So this is what is the neonatal severe hyperparathyroidism. The heterozygous form of this CSRD mutation is what is the familial hypocalcemia with hypercalcemia. So this is heterozygous. It's a mild hypercalcemia and probably what was seen in the previous generation. In this generation, this is basically had a homozygous form, so it results in severe neonatal hyperparathyroidism. These neonates are going to present with severe hypercalcemia, lethargy, hypotonia, seizures, and these are homozygous mutations. They need to be operated immediately. We do an urgent protein parathyroidism with autotransplantation. Sometimes we don't autotransplant, we just cryopreserve along with a thymectomy. So we don't do a septal section. So the operation choice for these neonates are very important. Total parathyroidism. So we don't do a septal section because there is a high chance of section. So we want to control the pattern very quickly. Okay. Let's go to the next question. 32-year-old lady with multiple pathological fractures, an evaluation with calcium of 14.5 with a pH of 2,800. A clinical picture and intraoperative picture is given below, which are the following statements regarding this condition are true. Most commonly, it is caused by retinoblastoma gene mutation. They classically show a capsular or vascular ablation. Cinacalcet is approved for use in this condition. This condition requires a prophylactic blood pressure. Let's look at this clinical scenario first. This is a young lady is presented with multiple pathological fractures. You can see here this is severe hypercalcemia, calcium more than 14 that qualifies for a hypercalcemic crisis. Now, along with this, we have also given a very high pH level. Normal pH level is usually limited around 75. So you can see this is more than 10 times the upper limit of the level. You can see this is you can see the clinical swelling that is seen in this patient. It is a palpable clinical swelling. And if you look at the improv in the picture here, the blue arrow here, you can see that gray structure that is the parathyroid lesion, whereas the pinkish structure superficial to it or anterior to it is the normal thyroid gland. You can see this grayish appearance is classical for parathyroid carcinoma. Now you can see how there is no distinct plane. Usually you get a distinct plane between the parathyroid and the thyroid. This large adenoma, no distinct plane with the thyroid. Palpable swelling, severe hypercalcemia with very elevated pH level. All these are pointing towards the malignancy. So the correct answer for this condition is that cinacalcet is approved for use in this condition. So remember, these the most common mutation associated with malignant parathyroid carcinoma is basically CDC73 mutation, cell division cycle 73 mutation. It's also known as the HRPT2 mutation. These are the most commonly mutated. Apart from that, we also have this GCM2 mutation. So the GCM2 mutations are what is associated with the familial isolated hyperparathyroidism. Now remember, cinacalcet, which is a calcium mimetic, can help regulate the pH levels. So this is classically found in classically approved for two scenarios. So one is either in secondary hyperparathyroidism or tertiary hyperparathyroidism. On the other hand, it is also associated with it is also approved for using severe hypercalcemia in parathyroid carcinoma. So the diagnostic criteria for diagnosing a parathyroid carcinoma is quite challenging. So you need to have vascular or capsular invasion. Of course, very important thing is presence of this trabeculae or a fibrous stroma. A lot of atypical mitosis, high number of mitosis. However, these are not commonly found. They sometimes be found even in a benign adenoma. Sometimes we call what is known as an atypical parathyroid adenoma. They also fit into these classical criteria. So this is something that is not a very strict criteria for diagnosis of the parathyroid carcinoma. So remember these two mutations, CDC73 and HRPT2 gene mutation. These are the most commonly responsible for parathyroid carcinoma. Retinoblastoma may be associated with sporadic parathyroid adenoma. Okay, let's look at the next question. This is a 38-year-old male IgA glomerulopathy with end-stage renal disease, and he has developed the following skin lesions. You can see the skin lesion in the anterior aspect of the shin here. Serum calcium is 9.5, phosphorus is 6.7, and zinc is 175. Which of the following are just a minute. Yes, welcome back. I apologize for that issues with the slides and the audio. So let's get back to our discussion here. So I'm just going back as per your request. We'll just go back a couple of questions. So we looked at this question, which is a 48-year-old lady with neck swelling for the last 10 years and scalp swelling for the last 6 months. Now we've given you the FNAC picture here. You can see classical microfollicular pattern. So when we say microfollicular pattern, basically it's not a papillary pattern. So that's what you should always look for. Two things: is it a papillary pattern or a microfollicular pattern? If it's a papillary pattern, then it's a more a papillary thyroid cancer. If it's a microfollicular pattern, then more points toward a follicular pathology. You can see here again there are no nuclear atypical features. Again, that is a classical feature, that it's not a papillary line of tumor, it is more of a follicular line of tumor. So this is a very classical clinical scenario, thyroid swelling with a pulsatile scalp metastasis. FNAC is showing a follicular picture. This is a follicular thyroid cancer. Now the options given here, FNAC is an easy diagnostic tool for malignancy. That is not a correct answer. Now when we look at a follicular uh, carcinoma, that is something that cannot be diagnosed on an FNA. So when we say follicular, when we say an FNA, when we get this kind of picture, you'll always, if you see a cytopathology report, the pathologist will always say only a follicular neoplasm. They may suggest that follicular thyroid cancer is a possibility, but they cannot say that it is a follicular carcinoma based on just an FNA, because you need to see capsular invasion to diagnose that it is a malignancy, and that is something that can be diagnosed only on a histopathology specimen, and that too it has to have proper capsular invasion to call it a follicular thyroid cancer. So FNAC is not a diagnostic tool for malignancy. You can only say that it is a follicular lineage of lesion. Now remember, when we talk about thyroid cancers, there are two pathways. So you have a mitogen activated protein kinase pathway, which is known as a MAP kinase pathway. These are more commonly associated with PTCs. All right, this is where your BRAF mutation comes into play. That's more associated with papillary thyroid cancers. On the other hand, you have these PI3K AKT pathway, which is more commonly associated with follicular lineage lesions. So basically, it is this is a follicular thyroid cancer. So that's more commonly associated with a PI3K AKT pathway, not associated with a MAP kinase pathway mutation. Now, intermediate risk group. Now, when we talk about follicular thyroid cancer, when we talk about ATA risk stratification, we have a low risk, we have an intermediate risk, and we have a high risk, right? These are the three different risks that we put the patient into. When we talk about follicular thyroid cancers, specifically, they are going to belong to either the low risk group or the high risk group. There is no intermediate group for follicular thyroid cancers. Now, the follicular thyroid cancers, basically, if they have a less than 4 extension into less than 4 vascular foci, then they become low risk. If they have intravascular extension more than 4 foci, then that becomes a high risk group. So there is no intermediate risk group in follicular thyroid cancer. And of course, association with PAX8 PPAR gamma mutation, that is the correct answer here. So I'm going to leave you with this particular table. This is straight from SWOTs. I'm not going to go through it in detail. Salient point you need to know is that basically your specific for follicular lesions, you have RAS mutations. Now it's a protein that is common to both MAP kinase pathway as well as PI3K pathway, but however more commonly associated with follicular adenoma and carcinoma. PAX8 PPAR gamma again associated with follicular adenoma and carcinoma. Now RET mutations, TRK1 mutations, BRAF mutations, all these are more commonly associated with papillary thyroid cancers. Beta-catenin, TERT promoter mutations, P53 mutations, all these are also associated predominantly with undifferentiated or dedifferentiated thyroid cancers. These are terminal mutations. Another important tumor suppressor gene is the P10 tumor suppressor gene that is associated with Cowden syndrome. Again, here also, this is specifically associated with follicular adenoma and carcinoma. So RAS, PAX8, PPAR gamma, and P10, these three are associated with follicular lineage of follicular adenoma and carcinoma. Okay, moving on. Next question, 24-year-old female with persistent hypercalcemia following a failed focused parathyroidectomy. Indus localization, you can correct this to left superior adenoma. Histopathologically, the suggested only a perithyroidal lymph node. So we went ahead and did a 4-dimensional CT. What is the correct diagnosis here? So you can see this is a picture of a 4-dimensional CT here. There is a hyper attenuating lesion that is found, shown by the red arrow here. This is found posterior to the common carotid and the IJV. Within the carotid sheath, you can see that this lesion is within the carotid sheath. So the options that are given here is it ectopic left superior or an ectopic left inferior adenoma? Is it a utopic left superior adenoma, or is it a false positive uptake in a level 4 lymph node? So remember, this is definitely not a utopic location. So this is an ectopic location. The usual utopic locations do not extend up to the carotid artery. So these are ectopic locations. So this is a classical ectopic left inferior parathyroid adenoma. Now remember, the parathyroid adenoma, the parathyroid glands, the inferior parathyroid glands especially have a longer migratory path. So they tend to have a more ectopic incidence of ectopia is more common with the inferior parathyroid glands. Now remember, the inferior parathyroid glands are going to come from higher up. So they are going to come from a third pharyngeal pouch, vis-a-vis the superior parathyroid glands, which are going to come from the fourth pharyngeal pouch. So these inferior parathyroid glands, during the time of migration, sometimes they may get arrested in their descent. So they may be found as high as even the skull base. It may be found angle of mandible. It may be found much higher than the normal superior parathyroid. So sometimes even within the carotid sheath. So this is a classical example of ectopic inferior parathyroid gland that was found in the within the carotid sheath. Moving on to the next question. This is a question where we've given a 14-hour-old neonate born by uncomplicated normal vaginal delivery who developed sudden onset seizures and lethargy. Now, metabolic evaluation was done. Calcium was 15, and they have also given you that the patient has family history of mild hypercalcemia in 2 previous generations. So, which is the most likely true statement regarding this condition? So that is the question that is being asked. Let's look at the options here. Heterozygous CASR gene mutation, homozygous PTH gene mutation, homozygous CASR gene mutation, or a heterozygous PTH related peptide gene mutation. So this is a very classical peculiar scenario, sudden onset severe hypercalcemia in a neonate. So this is a classical scenario where you have a homozygous calcium sensing receptor gene mutation. So the correct answer is C, that is homozygous calcium sensing receptor gene mutation. Now remember, they've also given us family history of 2 individuals who probably had mild hypercalcemia. So the same mutation, if you inherit in a heterozygous fashion, then it results in mild hypercalcemia, and it results in the syndrome which is what is known as familial hypocalciuric hypercalcemia, or FHH. So in neonates, when they have this homozygous form of this CASR gene mutation, it results in severe hypercalcemia and morbidity. So they may have lethargy, hypotonia, seizures, mental retardation, and the treatment of choice in these patients is to do a total parathyroidectomy. Remember, we don't do a subtotal parathyroidectomy in this patient because we want to achieve biochemical cure, and even if you leave a small remnant behind, that's a high chance of recurrence and it contributing to hypercalcemia. So we always do a total parathyroidectomy. We can sometimes auto transplant, or we may cryopreserve and transplant later, basically because we want to avoid permanent hypoparathyroidism, which is a very morbid condition. So this is a homozygous calcium sensing receptor gene mutation. This is a variant of, or it is a sister mutation that is found similar to familial hypocalciuric hypercalcemia, which is a heterozygous mutation. There it is mild hypercalcemia presence usually in adulthood, and you can manage even conservatively. You just have to treat the mild hypercalcemia. Okay, 32-year-old lady with multiple pathological fractures. On evaluation, calcium is 14.5 with PTH of 2800 picogram per ml. Her clinical picture they've given here, and they've also shown you the intraoperative picture below. Which of the following statements regarding this condition are true? This is a patient that we operated a couple of weeks back. So You can see here, this is a patient with severe hypercalcemia. Of course, it's a symptomatic patient, multiple pathological fractures, severe hypercalcemia with a calcium of 14.5. PTH is severely elevated, 2800. So usually upper limit of normal is around 75. So more than 10 times the elevation of serum PTH. Patient seems to have a palpable swelling in the neck, which is marked here in this clinical photograph. And you can see this intraoperative picture here. The blue arrow is pointing towards the parathyroid lesion. It has got a characteristic grayish appearance. The pink structure that is found on top or anterior or superficial to that parathyroid lesion is actually the normal thyroid lobe. So this is a classical example of a parathyroid carcinoma. You can see this grayish appearance, lack of planes with the surrounding thyroid, severe hypercalcemia, symptomatic patient, more than 10 times elevation of PTH. This basically denotes a parathyroid carcinoma. So the options here, it's not most commonly caused by a retinoblastoma gene mutation. Capsular vascular invasion, they are not classical features. Cinacalcet is the correct answer here. Cinacalcet is approved for use in this condition, and there is no role to do a prophylactic neck dissection in parathyroid carcinoma. So usually we do a neck dissection in a parathyroid carcinoma, either a central or a lateral compartment neck dissection, only if we find either preoperatively we have suspicious nodes or palpable nodes, or intraoperatively we find bulky central compartment disease or a lateral compartment disease, and then we plan for a selective neck dissection. So there is no role for a prophylactic neck dissection in parathyroid carcinoma. So most common mutations involved CDC73 cell division cell 73. It's also known as HRPT2 gene mutation. And we also have the GCM2 mutation. Now, GCM2 mutation is more commonly associated with familial isolated hyperparathyroidism, whereas CDC73 or HRPT2 mutations are more commonly associated with hyperparathyroidism jaw tumor syndrome. So these are two syndromes you need to know which are commonly associated with parathyroid cancer. Other syndrome that is associated, of course, MEN1 syndrome is also associated with parathyroid cancer. So that's another thing that you need to remember. Cinacalcet is a calcium mimetic. It can regulate the PTH level. It is specifically approved for two conditions. One is either in secondary or tertiary hyperparathyroidism with severely elevated parathyroid hormone levels, or in this scenario where you have a parathyroid cancer with severe hypercalcemia, refractory parathyroid cancer, severely elevated PTH level. In this scenario, again, cinacalcet is specifically applied for this. The possibility of diagnosing a parathyroid cancer usually is based on histopathology. It is a little difficult. Sometimes you have these atypical parathyroid adenomas, which may also mimic a parathyroid cancer. So capsular vascular invasion, trabecular pattern, fibrous stroma, mitosis, all these may also be found in a benign adenoma or an atypical adenoma. So it's not a very classical way to diagnose parathyroid cancer. Of course, we can also use IHC. We use something known as parafibromin. So parafibromin positivity comes only in the presence of a CDC73 mutation, which may be a sporadic or a germ-like mutation. So parafibromin on IHC is a specific marker for parathyroid cancer. Okay. 38-year-old male with IgA glomerulopathy, end-stage renal disease, has developed the following skin lesions. This is a hyperpigmented lesion in the shin. Calcium is 9.5, phosphorus is 6.7 with a PTH of 175. So you can see this is a classical example of a secondary hyperparathyroidism. The patient has normal calcium. So usually these patients have a normal or even a low calcium, along with hyperphosphatemia, that is the primary driver for the secondary hyperparathyroidism, along with a moderately elevated PTH. Now, the condition given here is what is known as calciphylaxis. So the options that are asked here is it does not have any relation to hyperparathyroidism, treated with sodium thiosulfate, subtotal thyroidectomy is the procedure of choice, or associated with a high calcium phosphorus product. The correct answer here is the false answer here is subtotal parathyroidectomy is the procedure of choice. So let's look at the little bit about calciphylaxis. So basically, calciphylaxis is you have calcification within the microvasculature that is supplying the subcutaneous plexus. So there is thrombus, basically increased calcium deposition. There is intimal fibrosis, and there is thrombosis that occurs within the subcutaneous vessels. So usually this is associated either with hyperphosphatemia, that is refractory to medical treatment. So despite giving phosphate binders, patient has hyperphosphatemia. Calcium as well as phosphate is elevated, so you have a high calcium phosphate product, very highly elevated PTH levels, sometimes use of warfarin, which can also have a prothrombotic effect. Protein C S deficiency, again prothrombotic, and other thrombophilic states can also cause this calciphylaxis in the background of secondary hyperparathyroidism. So now remember, the relationship between hyperparathyroidism and calciphylaxis is not definite. So sometimes severe secondary hyperparathyroidism, they may not develop calciphylaxis. People sometimes even with end-stage renal disease may have calciphylaxis, but they may not have hyperparathyroidism. So the relationship between secondary hyperparathyroidism and calciphylaxis is not something that is very definite and proven. So how do you manage? You can use sodium thiosulfate. We use phosphate binders again to bring down the phosphorus so that we can reduce the calcium phosphorus product. We sometimes use dialysis with a zero calcium dialysate or a low calcium dialysate that can again bring the calcium levels and help reduce the phosphate levels. Also, we can use calcium mimetics like cinacalcet. Again, they bring the PTH level down, they bring the calcium level down as well. And of course, parathyroidectomy is definitely indicated in these patients. So remember, it is always important to do in these patients to do a complete resection. So we prefer to do a total parathyroidectomy with a thymectomy, and sometimes we may do a autotransplantation or a cryopreservation and a autotransplantation at a later time. So we don't prefer to do a subtotal parathyroidectomy because of the high chance of recurrence in these patients. So that's the that is a calciphylaxis in a nutshell. We explained calciphylaxis and why we have chosen that as the correct answer. Moving on to the next question. 12-year-old presented with dyspepsia and bony pain. Evaluation revealed hypercalcemia with elevated parathyroid hormone and normal phosphorus. He was detected to be positive for a frame shift mutation at 11q1213. Which of the following are appropriate in the management of this condition? So let's look at this clinical scenario. Dyspepsia and bony pain. So you can see here, patient has hypercalcemia, elevated PTH with a normal phosphorus. So that again fits in basically inappropriately elevated parathyroid hormone level. With bony pain, that is probably a primary hyperparathyroidism. Very important, the patient has been diagnosed to have a frame shift mutation at 11q1213. This is the genetic locus associated with MEN1 syndrome. 11q1213 frame shift mutation are the most common, almost 45% are frame shift mutations. So let's look at the options here. Cervical thymectomy is advocated to prevent the development of thymic carcinoid. That is not correct. During bilateral neck exploration, only the abnormal parathyroid is excised. Again, this is also not a correct answer. Total parathyroidectomy is a procedure of choice due to high chance of recurrence. Again, this is also not a correct answer. MEN1 syndrome, it is not like total parathyroidectomy is one of the options. So we can either do a subtotal parathyroidectomy or we can do a total parathyroidectomy with autotransplantation. Both options are available. Subtotal is what is more commonly done, more preferred because it basically reduces the chance of permanent hypoparathyroidism. Total parathyroidectomy has a higher chance of permanent hypoparathyroidism, but has a lower chance of recurrence. So more number of people do a subtotal parathyroidectomy as against doing a total parathyroidectomy with an autotransplantation. Now, the last operation, preoperative localization studies may be used for localization of ectopic or supernumerary parathyroid gland. So that is the correct answer in this question. Now, remember, in MEN1 syndrome, most commonly it is a multiglandular disease. It's parathyroid hyperplasia, asymmetric parathyroid hyperplasia involving more than one gland. So in MEN1 syndrome, we don't use preoperative localization study to localize the abnormality for surgery. As against primary hyperparathyroidism, in order to do a minimally invasive focused exploration, we use a preoperative localization study. But here we are going to use preoperative localization study basically to localize whether there are any ectopic or supernumerary parathyroid glands. So if you see in normal patients, about 5 to 15% you can get ectopic or supernumerary glands, whereas in multiglandular disease or familial hyperparathyroidism, this number may go up to 30%. So almost 30% of patients may have supernumerary ectopic glands. So if all 4 glands are abnormal, do a subtotal parathyroidectomy where you remove either, you basically do 3.5 gland excision, leave behind a half gland remnant which is equal to the weight of one normal gland. Along with that, we do a transcervical thymectomy because the thymus is the most common site for a supernumerary parathyroid gland in 13%. Only in meant to be syndrome, we resect only the visible enlarged parathyroid. In a men one, we always do a bilateral neck exploration, see all the 4 parathyroids, do a 3.5 gland excision. Meant to be, you see if there are any enlarged parathyroid glands and you excise them only, because they are the risk for parathyroid hyperplasia is lesser. It's more of a pseudo adenomatous change in meant to be syndrome. So again, parathyroid imaging more likely to identify supernumerary or ectopic parathyroid glands to reduce the risk of recurrence in secondary hyperparathyroidism or familial hyperparathyroidism, which is basically multiglandular disease. Okay. 60-year-old male with bony pain, bone deformity, and multiple lesions on the X-ray. You can see the X-ray given here. You can see these multiple lesions, multiple lytic lesions within the cortex of the bone. His serum calcium was 10.2. Serum phosphorus was 6.5. Serum PTH was 154. Serum creatinine was 1.9. The vitamin D of 14. IOPTH values are given. What is the appropriate procedure of choice? So you can see the IOPTH values. Pre-incision IOPTH is 148. Pre-excision is 164. 5 minutes is 100. 10 minutes is 98. And 20 minutes is 90. So when we talk about IOPTH, we need to know what is known as the Miami criteria or University of Miami criteria. This is basically you have to have at least a 50% fall at 10 minutes compared to the preoperative values. That may be either the pre-incision value or the pre-excision value. Highest of these two you have to take. So if you look at the pre-incision 148, pre-excision 164, we'll take the highest value. So we take 164. So by 10 minutes, it should have dropped to at least 82. So here you can see you have not had a 50% drop. So it's 98, and even at 20 minutes, it's not dropped to the 50% value. So this is a classical example of a multiglandular disease. So in this kind of patient, what will you do? Bilateral neck exploration with focused parathyroidectomy? No, that's not what we do. Unilateral neck exploration with a subtotal parathyroidectomy? Again, that's not something we do for a secondary hyperparathyroidism. Bilateral neck exploration, subtotal parathyroidectomy, or a minimally invasive focused parathyroidectomy. The correct answer here is that you have to do a bilateral neck exploration and a subtotal parathyroidectomy. So in this clinical scenario, usually what we do is, if we have not achieved a biochemical cure, that means we have not excised the adequate amount of tissue. So we go ahead and excise the next gland also. So that's how we proceed, go on excising gland after gland till we achieve IOPTH that fits into the Miami criteria. So we, in a secondary hyperparathyroidism like this related to chronic kidney disease, creatinine of 1.9, a high calcium, or actually it's a borderline high calcium, high phosphorus, PTH of 154, creatinine elevated. Here you've not had an IOPTH fall, so definitely you cannot do a focused parathyroidectomy. You have to do a bilateral neck exploration, and of course, in the given options, you would choose to do a subtotal parathyroidectomy. So bilateral neck exploration, subtotal parathyroidectomy is the procedure of choice for a secondary hyperparathyroidism. Okay. Again, for bilateral exploration, any failure of focus exploration, PTH does not drop as per the protocol, then you definitely have to convert the focus to a neck exploration. And as I already mentioned, we take these 4 values: pre-incision, pre-excision, 5 minutes, and 10 minutes. And depending, we take the higher of these two. And the Miami criteria says more than 50% decline at 10 minutes compared to the higher value between the pre-incision and the pre-excision value. Sometimes we use dual criteria also, which requires, apart from this fall, you should also have the PTH within normal range. So important to understand what is Miami criteria and what do we do for a secondary hyperparathyroidism. Okay, let's look at this question here. 24-year-old girl with fracture of the neck of femur following trivial trauma. Her father and one sibling also had similar complaints. General examination is shown below. What is the likely genetic locus involved? You have to pay careful attention to this clinical picture. You can see there is a hyperpigmented patch in between the scapulae. So the interscapular region has this hyperpigmented patch here. So they are asking what is the likely genetic locus involved here. So this is a classical example of a cutaneous lichenoid amyloidosis. All right. So this is what is known as a CLA, or a cutaneous lichenoid amyloidosis. So again, if you look at the options here, this cutaneous lichenoid amyloidosis, the minute you see this, you know that this is a MEN 2A syndrome. And the minute you see this particular general examination finding in a patient, you know this patient has a 634 codon mutation. So the correct answer here is A, chromosome 10q11.2. Again, that is a locus that is for a red oncogene mutation. And the codon involved is 634. This is a specific codon that is involved with the cutaneous lichenoid amyloidosis. So spot diagnosis, you can make a genetic diagnosis based on just this single clinical feature. Other options, of course, codon 883 is associated with MEN 2B, and there you don't get CLA. Again, it's not a chromosome 11 mutation. 918, again, MEN 2B, it's a chromosome 10 mutation. 620 is not associated with, it's associated with MEN 2A, but it is not associated with cutaneous lichenoid amyloidosis. So that's a very important point that you need to take away from this question. So in contrast to MEN 1, genotype-phenotype correlations are very, very good in MEN 2 syndrome. So 635 mutation is more likely to develop hyperparathyroidism. So the risk of hyperparathyroidism in MEN 2A is about 20 to 25% or 15 to 30%. And the patients who have 635 mutations are more likely to develop this hyperparathyroidism. Okay. 32-year-old male with underwent a focused parathyroidectomy for a left inferior parathyroid adenoma. His IOPTH and postoperative biochemical investigations are given below. What is the appropriate next investigation? So this is a similar scenario that we've given to the previous question where we saw IOPTH values. So this is something that you can get in your exams. They may give you IOPTH values and you will have to figure out whether it is what kind of disease it is. So here you can see, again, there is no fall of more than 50% at 10 minutes compared to the pre-excision or the post-excision or the pre-incision or the pre-excision values. Pre-op calcium was 11.5. The post-op calcium is also still high, 10.8. So this is a classical example of a persistent hypercalcemia. So remember, we have something called a persistent and a resistant. And a recurrent. Persistent is basically within 6 months, if the calcium comes back to being high, that's a persistent hypercalcemia. More than 6 months after becoming normal, it becomes high, then it's a recurrent hypercalcemia. So here this is a persistent hypercalcemia. So what is the appropriate next investigation? Ultrasound system, maybe parathyroid venous sampling, 4-dimensional CT or a contrast enhanced MRI. The correct answer here is you would do a 4-dimensional CT. Now remember, we are talking about a redo parathyroid or a failed parathyroid surgery. So 4D CT is imaging a modality that is being recommended for this particular scenario where we have a reoperative patient. We've had a patient who's undergone surgery, failed parathyroid surgery. Especially in these patients, 4D CT is very useful. So the sensitivity specificity is quite high, almost 90%. And especially in reoperative cases, to localize small adenomas, abnormal glands, ectopic sites, even in mediastinal sites, all these sites, it's very useful to use a 4-dimensional CT. Now, limitations of 4D CT is, of course, you have a high RT, and because you use IV contrast, you may sometimes get even artifacts because of the metallic implant. So that is also another disadvantage. Radiation is a very significant concern with 4D CT because of the different phases that we use. It's got almost 27 millisieverts of exposure of radiation. So that's something that is a concern with 4D CT. Now, if the question said which is the first line investigation, then you can go with ultrasound system, because even in a redo operative patient, we always relocalize the disease, we redo the biochemical diagnosis, we relocalize. So the first investigation is still ultrasound with system EB, but among this, the most appropriate investigation is a 4-dimensional CT. Now, if a 4-dimensional CT or a MRI does not give us the answer, then we move on to the invasive modalities, which are basically parathyroid venous sampling, or we can use parathyroid angiography. So these are all options that we have. These are invasive options that are not used as first line for reoperative. First line for reoperative parathyroid surgery or redo parathyroid surgery or failed parathyroid surgery is to use a 4-dimensional CT. Okay. 14-year-old with resistant hypertension, weakness of lower limbs. Evaluation revealed aldosterone of 62 nanogram per deciliter, plasma renin activity of 0.3 milligram per ml per hour, nanogram per ml per hour, potassium of 3.2. Administration of 0.5 milligram of dexamethasone 4 times a day resulted in reduction of hypertension. What is true regarding this condition? So you can see here, this is a classical scenario where they've given us elevated aldosterone level, 62, more than 15 is elevated. Plasma renin activity is 0.3, again, less than 1 is low. So you have an elevated aldosterone with a low plasma renin, with a borderline low potassium. And they're telling us that administration of dexamethasone resulted in resolution of hypertension. So this basically is a familial classical example of a glucocorticoid remediable familial hyperaldosteronism. So the options here, KCNJ5 mutation in the KIR3/4 potassium channel, that is not something that occurs in this particular type. That's something that occurs with type 3. This is a type 1. So type 1 is what is known as a glucocorticoid remediable familial hyperaldosteronism. It is caused by an ACTH independent mechanism? No, this is caused by an ACTH dependent mechanism. That is why when we give dexamethasone feedback inhibition, it reduces the ACTH, and that's how the hyperaldosteronism also reduces. Now, it is autosomal recessive. No, it is not autosomal recessive. This is autosomal dominant. And yes, it is caused by chimerism of this CYP11 beta hydroxylase enzymes. So let's look at the explanation for this answer. The correct answer is chimerism. So basically, type 1 is glucocorticoid suppressible or glucocorticoid remediable hyperaldosteronism. As I already mentioned, autosomal dominant. Here, basically what happens is two CYP enzymes, 11B enzymes are going to become chimerized. They're going to get fused. So CYP11B1 and CYP11B2. The CYP11B1 is basically involved with the cortisol synthesis. 11B2 is involved with the aldosterone synthase. So once these two are chimerized, the ACTH, which usually has an effect only on the glucocorticoids, starts to have an effect on this hybrid enzyme also. So because the ACTH has an influence on the hybrid enzymes, low ACTH level will cause a low aldosterone level as well. So this is a classical example of a type 1 familial hyperaldosteronism. Okay, moving on to the next question. 35-year-old female with right adrenal incidentilloma. She has a short stature, increased body hair growth, breast underdevelopment, deep voice, and a single perineal urogenital orifice. Which of the following statements are true regarding this condition? So this is a classical clinical scenario where we are giving a 35-year-old female patient with virilization. You can see these developmental anomalies and anomalies in the genitalia, short stature. So all this fits into some sort of adrenal hypoplasia or adrenal dysplasia. So this is a classical example of a CAH or a congenital adrenal hypoplasia. So the option given here, 17 hydroxylase is the most common cause. It is due to complete deficiency of the enzyme. There is severe hyponatremia associated with this condition, or 17 hydroxyprogesterone and androstenedione are elevated. The correct answer here is you have elevated 17 hydroxyprogesterone and androstenedione. Now remember, in a congenital adrenal hypoplasia, the most common enzyme involved is a 21 alpha hydroxylase. So the 21 hydroxylase enzyme is the most common deficient enzyme in the entire spectrum of congenital adrenal hypoplasia. Usually there are two spectrum of disease. One is a complete deficiency. So in a complete deficiency, usually these are symptomatic at birth in the neonatal period. So they usually may not even survive up to the adulthood. And they have severe salt wasting. So usually they're associated with severe hyponatremia. Whereas this partial deficiency spectrum, these patients, they may sometimes grow up to adulthood. They don't have much of salt wasting. However, they have the virilizing features. Now, why the virilizing features occurs is because of the 21 hydroxylase deficiency, there is more accumulation of pregnenolone, which gets converted to its other intermediates, finally resulting in elevated DHEAS, elevated androstenedione. So that is why you have elevated 17 hydroxyprogesterone, elevated androstenedione, and these are all responsible for the increased virilizing features. All right. So again, 21 hydroxylase is most common, more than 90%.
So usually you have a deficiency of glucocorticoids and mineralocorticoids. So there is reduced production of deoxycortisol and the deoxycortisone from their precursors. On the other hand, because of the reduced glucocorticoids and mineralocorticoids, feedback mechanism is going to increase the ACTH production. So because the increased ACTH acts on the pregnenolone, there will be increased pregnenolone production that will keep, instead of coming down to form the glucocorticoid and mineralocorticoid, it will parallelly get converted by the 17-hydroxylase enzyme to form 17-hydroxyprogesterone and androstenedione that results in virilization. So complete deficiency at birth, severe symptoms with salt wasting. Partial enzyme deficiency, they don't have salt wasting usually. They have more of virilization symptoms and they usually present later. Usually in adult, they may even present up to adulthood. These are rare presentations. Okay, 62-year-old male with complaints of weight gain, abdominal striae, poor vision and headache. On evaluation, he was found to have the following biochemical parameters. MRI brain was done, which is normal. What is the next step? So let's look at the answer. The values given here. You have a serum cortisol of 5.2, which is borderline high. Overnight dexamethasone suppression is 3.5. This is again not suppressed. We have the cutoff is 1.8, so it has to be less than 1.8. So here it is not suppressed. ACTH is 54. Now that is an elevated ACTH. So basically ACTH, any ACTH more than 15 is counted as an elevated ACTH. So this is basically a hypercortisolemia, and this is an ACTH dependent hypercortisolemia. Now the other options that are given here, we've got a high dose dexamethasone suppression test, which is 0.7. Again here also the cutoff is 1.8. So this is suppressed. And if you look at a CRH stimulation, the ACTH is 35, so that is basically not suppressed. So what is the next step? So all these biochemical parameters are pointing towards an ACTH dependent hypercortisolemia or ACTH dependent Cushing syndrome, again because of your unsuppressed HDST and lack of CRH stimulation. This is basically pointing towards a pituitary Cushing's disease. Now here, this is a pituitary Cushing disease. You can see the MRI brain is normal. So what do you do? The next step, subtotal hypophysectomy, pituitary RT, gallium-68 to look for ectopic source, or a bilateral inferior petrosal sinus sampling. So the correct answer here is, obviously we don't need to look for an ectopic source, because if it was an ectopic source, you will not have a high dose dexamethasone suppression test suppressed, and CRS stimulation also will have suppression. So you can see here the correct answer, because there is no lesion on the MRI, we need to do a bilateral inferior petrosal sinus sampling. So you don't go and do a subtotal hypophysectomy for these patients, because then they tend to go into a pan hypopituitarism. So you at least need to lateralize to know which part of the pituitary you need to remove. And pituitary irradiation again has a higher risk of pan hypopituitarism, and usually it is reserved for persistent or recurrent cases of Cushing's disease. So as I already mentioned, corticotrophic adenomas, that is basically the Cushing's disease, will definitely have suppression in response to HDDST, whereas ACTH will not have that. And remember, if you have a pituitary mass that is more than 6 mm with biochemical ACTH dependent Cushing syndrome, then you can proceed for surgery. However, if you don't have a demonstrable mass on the MRI, then the next step will be to do a bilateral inferior petrosal sinus sampling. So you have to basically, you need to do a central to peripheral gradient, and if you don't have an adequate gradient along with a lack of suppression on a high dose dexamethasone suppression test, then that indicates basically a ectopic source of ACTH dependent Cushing's syndrome. So here you need to do usually we do a gallium-68 PET CT to look for a ectopic ACTH source. Okay, let's look at this question. 28-year-old male with headache, palpitation, and epistaxis with resistant secondary hypertension. Which of the following is the best modality for functional imaging of this patient? So let's look at the hormonal evaluation here. Now they've given us a plasma aldosterone concentration of 7, plasma renin activity of 1, urine metanephrine of 1240, and a urine normetanephrine of 2287. These are all values that are given to slightly confuse you. Now you can see here very clearly this patient could be anything. Resistant secondary hypertension could also be primary hyperaldosteronism. However, here the plasma aldosterone is normal, renin activity is also normal, so there is no elevated aldosterone or suppressed renin. On the other hand, urinary metanephrine, norepinephrine is elevated. So this is a classical diagnosis of a pheochromocytoma or a paraganglioma. So what is the best modality for functional imaging of this patient? I-131 MIBG, NP59 scintigraphy, F18 F-DOPA or a gallium-68 DOTA PET. So the correct answer here, NP59 scintigraphy is not the correct answer. This is something that we use more for cortical imaging. So adrenal cortical lesions, especially a primary hyperaldosteronism or a Cushing's cortical adenoma, we can use as NP59, which is basically a cholesterol-like molecule which is not metabolized, so that tends to concentrate in the adrenal glands. So you can use it, especially if you are looking for something like a PPNAD, which is a primary pigmented micronodular Cushing's adenoma, which may be biochemically Cushing's but may not have visible nodules on the CT. Then NP59 is a good modality. MIBG, F-DOPA and gallium-68, all three are useful for functional imaging of PO or paraganglioma. Now remember, MIBG is specific, but sensitivity is low, 77 to 90%. And when we use other modalities, we can of course use PET-CT or we can use DOPA molecules like F-DOPA or F-dopamine. The best PET-CT tracer that we use is basically a gallium-68 dotatate. Now it has a good lesion detection comparable to FDG PET. So remember, gallium-68 dotatate is not only used for neuroendocrine tumors or somatostatin receptor positive tumors. It can you can also use it for a wide range of spectrum. Like for example, it can be used for medullary thyroid cancers. It can be used for pancreatic neuroendocrine tumors. It can be used for pheochromocytoma paraganglioma syndromes. All these are also basically neuroendocrine tumors. That is why gallium-68 dotatate PET-CT is considered the best functional scan for pheochromocytoma. Okay, 32-year-old lady with frontal hair loss, deepening of voice and hirsutism for the past 3 months. Evaluation shows a 6 into 7 centimeter right side adrenal mass. You can see the picture here with central necrosis. Which of the following statements are true regarding this likely pathology? So what is the correct pathology here? So this is a classical example of a adrenocortical cancer. Now you can see here adrenocortical. Why I'm saying adrenocortical cancer? Reasons is, one is a large adrenal mass, more than 6 centimeter in size. It is heterogeneous mass. It has got central necrosis, and this patient also has virilizing features. So these are all classical symptoms that you get with a adrenocortical cancer. So let's look at the options here. Mitotain monotherapy is most efficacious in treatment of unresectable ACC. Streptozocin-based regimens are primary regimen of choice. EBRT is an excellent modality to prevent local recurrence, or mitotain reverses resistance to chemotherapeutic agents. Now remember, mitotain monotherapy is a treatment of choice. However, in unresectable ACC, that is not favored. We use mitotain monotherapy usually in high risk ACC post-operatively. So you do the surgery, you have a high risk lesion which is NSAT 3 or more, or it has a Ki-67 more than 10%. These kind of tumors are high risk category, so they basically will require some form of adjuvant therapy. So you can add on mitotain to those patients. Whereas in low risk category, NSAT 1 or NSAT 2 with a Ki-67 less than 10%, you can avoid mitotain. Streptozocin-based regimens were previously used for management of ACC. Now, after the FIRMAC trial, it is shown that use of etoposide, doxorubicin, and cisplatin along with mitotain has a better progression-free survival. So that's what we use currently. EBRT is something that is not very useful. It may be used for avoiding local recurrence, but that's not commonly recommended throughout. It's not a very great modality. These tend to be radio resistant. And yes, mitotain does prevent resistance to other chemotherapeutic agents. So in vitro data has indicated that mitotain may be able to reverse this resistance when combined with various chemotherapeutic agents. So this is a very important point. And you have to remember the FIRMAC trial, which is basically mitotain along with EDP in comparison to streptozocin based regimen, which has shown that EDP with mitotain is far superior to streptozocin based regimens. Okay, 68-year-old male with a BMI of 35 kilogram per meter square, diagnosed with a left adrenal mass measuring 4.5 centimeters as shown in the CT. You can see here this left adrenal mass here. What is the most appropriate approach for this patient? Supine open transperitoneal left adrenalectomy, prone open retroperitoneal open adrenalectomy, laparoscopic transperitoneal adrenalectomy, or a retroperitoneoscopic adrenalectomy. So this is a left-sided adrenal mass, 4.5 centimeters, 68-year-old male with BMI of 35. So the correct answer to this question is you would prefer to do a laparoscopic transperitoneal adrenalectomy either in a supine or in a lateral position. So of course, laparoscopy is better than open surgery, reduced length of stay, better pain control, lower risk of complications, better time to ambulation, reduced intraoperative blood loss. When we compare lap versus retroperitoneoscopic, both are similar. Retroperitoneoscopic does not require the use of the penetration of the peritoneum. So actually it has an even faster recovery. Now remember, the issue with retroperitoneum is in lesions that are smaller than 6 centimeters, bilateral tumors, and patients who have had previous abdominal surgery, definitely retroperitoneoscopic is useful. It's important to avoid this in obese patients. So in obese patients, it's a bit difficult because of the amount of retroperitoneal fat. Older patients, obese patients, male patients, again, the initial entry space creation is a little bit more difficult, especially on the left side because the left adrenal is placed more medially towards the midline. The left adrenal is a little bit more difficult to approach from a retroperitoneoscopic point of view as compared to the right adrenal. So severe obesity, BMI more than 35, again will there be a lack of space because of the compression of the retroperitoneum by the intra-abdominal visceral fat, especially in the prone portion. And so that in those kind of obese patients, we may tend to avoid retroperitoneoscopic approach. However, this is something that can still be attempted by a highly experienced retroperitoneoscopic surgeon. Okay, so the last question for discussion today, which of the following are statements that are false for adrenal venous sampling in primary hyperaldosteronism? All patients must undergo adrenal venous sampling to differentiate between unilateral versus bilateral hyperplasia. It may be avoided in suspected adrenocortical cancer. Patients with high-risk comorbid conditions unfit for surgery, you can avoid doing adrenal venous sampling, or it may be avoided in a type 1 or a type 3 familial hyperaldosteronism. So what is false regarding these statements for adrenal venous sampling when we're talking about primary hyperaldosteronism? So the correct answer here is all patients must undergo AVS. So we don't recommend universal adrenal venous sampling. Again, there are various people in the world who follow different protocols. There are some people who still do adrenal venous sampling for all patients, irrespective of their age and so on and so forth. But we adopt a selective. So most commonly in the world, what is adopted is a selective adrenovenous sampling to differentiate between unilateral or bilateral hyperplasia. So remember, especially in a situation where you cannot localize the tumor, you're not able to get an anatomical. So if you have a classical cortical adenoma with a typical biochemical diagnosis of primary hyperaldosteronism with hypokalemia, you don't really need to go ahead and do a adrenal venous sampling. Whereas if you cannot localize the lesion on CT, or if there is a bilateral enlargement, or if the opposite adrenal is bulky, you are suspecting a bilateral disease, then in these kind of patients, elderly patients, again, they tend to more have hyperplasia. So these are scenarios where you may consider adrenal venous sampling. So suspected ACC, you don't need to do an adrenal venous sampling. Any comorbid conditions, we're not going to go for surgery, then again, you don't need to do an adrenal venous sampling because it's a invasive procedure. And any familial hyperaldosteronism, a type 1 or a type 3 familial hyperaldosteronism, you don't need to go and do a adrenal venous sampling. So with this, we have come to the end of today's discussion of the 25 clinical questions for NEET super specialty. I hope you guys had a fruitful time discussing the questions, the clinical scenarios, and the options. I apologize for the hiccup that we had with the audio visual. I hope that was not too much of an inconvenience. I think with this, we can conclude today's session. I hope you had a fruitful time with me. Wishing you all the very best for the NEET super specialty exam in November. Hoping that all of you will do very well.